Oh, yeah.
Good morning, good afternoon, good evening, wherever you are. Welcome to Virtual Grand Rounds. Premier education brought to you at no cost thanks to our sponsors, AstraZeneca, Medtronic, and Medela, the Science of Care. I'm Eric Lim, and this week it's a great delight for me to present Dr. Rebecca Duerden, who was involved in the development of British guidelines on the diagnosis of anterior mediastinal lesion guidelines. Rebecca, over to you.
Thank you very much. I'm Rebecca Duerden, and I'm one of the radiologists based in Greater Manchester, and also a member of the BTOG Thymic Malignancy Specialist Interest Group. I have no disclosures. So, background to the guideline development. Several years ago, immediately prior to COVID, actually, interested members of BTOG looked to work together to try and get some guidance for imagers, clinicians, surgeons, for managing the incidental thymic lesions that are increasingly being picked up through the CTs that are being done on patients, for example, lung cancer screening, CTPAs, trauma scans, which previously we weren't picking up. We obviously had a little break because of COVID, but then when we were moving back to business as usual, the group met up. And as you can see from the list on the side, there was a broad range of specialty representatives within the group to make sure that we encompassed all aspects of the problem of dealing with thymic lesions appropriately. Once we'd pulled together the document and the guidelines through iterative best practice discussions, we then shared these with British groups, including the British Society of Thoracic Imaging, Surgical Society, and the Lung Cancer Clinical Excellence Group. And then we have made appropriate adaptations following their feedback as well. So these are published, and at the end I will show you a link to be able to download the publication. But here in summary is the actual pathway that we have pulled together. And I'm going to pull this apart and go through the rationale for all the different steps as we go forwards. What we're going to look at is how to get a patient through the pathway. And as you can see, just showing you here, there are some interlinking foci in the pathway, specifically between thymic cyst going into suspected thymoma. So mostly they are separated into this boxed area that is considered benign. But then as you move across towards the right of the screen, they become more and more malignant. And this is to try and help people with a progressive lesion in the mediastinum. So firstly, we're talking about the background rationale. The key context here is the clinical information that we've got. Now, I could be a moaning radiologist and complain I don't always get the information that I need, but hopefully this will help support all imagers to get that information through at the point of requesting imaging or your imaging review. So the first important thing is to think about patient treatment and whether or not they are fit for any treatment, and what their comorbidities are. That needs to be clearly documented, and also what their wishes are. Do they want to have surgery? Are they interested in any chemotherapy, radiotherapy options? Do they want just best supportive care? And then next important is, are there any myasthenic or other related symptoms that could be caused by a thymic tumour? We'll talk about this a little further in a minute. And then very importantly, we need to think about the patient's age. Obviously, younger patients do get thymic lesions. So if we can do a low dose or no dose procedure to further image and follow up, that should be taken into consideration. We have to make sure that we've got an understanding of whether or not different imaging modalities can be used. For example, patients with pacemakers may not be able to go in an MRI scanner depending on the location that is scanning them. And also you need to think about things like claustrophobia for MRI. And then you've got the problems of contrast and whether the patients have a contrast reaction or a risk of a contrast-induced nephropathy for CT validated agents. We have to make sure that we've looked at all previous imaging, particularly going back as far as we can, because if there is temporal evolution of a lesion, that is incredibly important to note. But similarly, if there is stability of a lesion for many years, this is going to be a benign lesion. So this is a key point. And it's important to make sure that all potential imaging is looked at, not just a CT of the chest, but chest X-ray might be able to guide, MRIs, etc. We do need to know if there is a concomitant disease that might be driving an atypical hyperplasia, more on this shortly, but also if that has been noted, has there then been a change in the size of the thymus following treatment? So having gone through all of these, we have this box at the top of the algorithm, which is covering some of those areas. And if we've got a young patient who is looking like they've got just a thymic remnant, we don't do any more imaging on those patients. And we've also got to look at the previous imaging if they're a young patient to see that there hasn't been an interval growth. It should be gradually getting smaller over time. So there was a study performed, this was actually within the cervical extent of the thymic tissue in younger patients. And there was clear evidence of evolution over time of this perceivable area on neck imaging. And we can assume that this is the same. Nobody's done the same evaluation within the thymus itself, within the mediastinum. But there's less motion artifact in the neck, so it's more reliable for measurements. And it's important to note that within the middle ages of life, most people have involution of the thymus. And this is normal, but if you look, there is a range, so therefore presence of thymic tissue may just be normal residual thymus tissue. How do we tell the difference between involution versus hyperplasia? Mostly it's to do with the shape of the thymus and the other characteristics that you can see on the imaging that you have. So we do have some more data on this, and a study published in 2016 covered more than 2,500 patients with a mean age of 59 years. And that showed that in over the 2,500 patients, about 3/4 had complete fatty replacement of the thymus. But there was a significant proportion that didn't have complete involution, and about 7% had both half fatty and half soft tissue present. So again, this comes back to reviewing previous. If this is normal for this particular patient, you can be reassured that they've just not involuted to a purely fatty thymus. Interestingly, my learning has always been, we would expect to see not much thymic tissue by 30. However, this study showed that it was over 50s, where you're going to see about 80% of them having complete fatty replacement, which is, changed my view of what I'm looking at now as a radiologist. One of the other points that we found on this study was that female patients have higher proportions of soft tissue visible in middle age than men do. And that can affect chemical shift assessment. So that's an important thing to know for any images or when you're reviewing MDT. And the other thing that's relevant for current population size, metaphorically and physically, is that we have got an increased risk of obesity within the general population. And when you've got a higher BMI, you tend to have more fat in the anterior mediastinum, so that can affect the soft tissue as well. And also ex-heavy smokers will tend to have more fatty anterior mediastinal / residual thymic tissue. And of course, this is the population who undergo screening. Rationale for advice, further looking down this box, interval change, we've mentioned already. More than 2 years of interval change is reassuring. However, If there are any concerns of myasthenic symptoms, positive antibodies, or other associated immunological conditions, even if you've not got interval change, then that might need review and possible resection. So these are the kind of things we've definitely got to take into account. Any growth or evolution in the appearance of a lesion is concerning and should be followed up. And we've recommended in the first instance using a contrast enhanced CT chest to help delineate the presence of enhancement. So here's as an example of, this is a thymic tumour, it's a thymoma, but what we have here is 3 different attenuations within the lesion. There's one that's cystic, and then 2 that are solid with different levels of enhancement. Why did we do this rather than recommending an immediate MR? It's easily available, people are used to reporting it, you've got good spatial resolution, it's relatively cheap, and it gives you a good baseline to be able to follow up from in the older population. So we wanted to make sure we had something that was practically applicable for most patients' follow-up. Please do remember that a non-contrast low-dose CT, as used for screening, or a CTPA in arterial phase does not show tissue enhancement. You need portal venous phase, which is 60 to 70 seconds. And therefore, it may be you need to repeat imaging in the shorter interval than annually in order to assess for enhancement in the first instance. So this is a germ cell tumour. Mentioned already the need to look for other associated symptoms. As you can see, there's a very large list of thymic related associated symptoms with a very broad range of clinical presentations and different autoantibodies that need testing or other diagnostic tests. So it is important, if you do have suspicion of one of these, to involve your appropriate medical support teams, such as immunologists, and they were part of the group working on this. Obviously, myasthenia gravis can occur after diagnosis and after thymectomy, and therefore we need to know what the baseline status is, and we need to make sure that we have evaluated this in all patients who have got a thymic lesion, including cysts, as the development of solid components in cysts can be difficult to evaluate initially. So we need to know baseline for those patients as well. So talking about benign appearances, it can be challenging to be certain on CT if it's purely cystic. Usually you get enough spatial resolution to see areas of wall enhancement and nodularity. But we do suggest that where we can, that we get a MRI to confirm that there are no enhancing components post-gadolinium. The problem we have though with MR is the spatial resolution is not as good as CT. So we really want the lesions to be in the region of 2 centimeters to be confident that what we're looking at is going to be accurate because of that spatial resolution limitation. Obviously, we've got the differential of thymic hyperplasia, which we'll come on to shortly, and that can be convex and triangular, as well as fatty within it, and chemical shift artifact evaluation on MR is really helpful for those patients. We have said in the guidelines that benign stable features of more than 4 years, then we can consider discharge. However, if there is any clinical concern, then we would need discussion at MDT. So this is a benign appearing cystic attenuation lesion on CT, courtesy of my colleague, Dr. Whittaker. And you can see that it sits within the anterior mediastinal margin on sagittary formats. On MRI, it has not got any obvious solid component, and we cannot see a definite area of enhancement. So we followed this for 2 years and it is stable. So we're confident that this looks like it's going to be a benign lesion, and it should potentially be able to be discharged because we've not got any positive antibodies or symptoms. So with thymic hyperplasia, there are 3 forms. Most are true or lymphoid, and then there's the rarer thymic hyperplasia with sialadenitis-like features. So the true hyperplasia is a rebound hyperplasia related to stress with a long list of causes, whereas the lymphoid hyperplasia is associated with other rheumatological conditions. So again, that information is essential to provide for your imagers so that they know that they are looking potentially at one of the lymphoid hyperplasias, and it may precede clinical symptoms as well, so that's important to note. Again, MR is used typically for these patients where possible, but if it's an older patient or there's a reason not to do that, you can consider follow-up with CT. We would advise that we discharge if there is a stability and you're happy that this is related to another condition. And particularly if following treatment for that condition, there's reduction in size, you can then be confident you're safe to stop follow-up. The thymic the thalassa is rare and autoimmune condition, and it's associated with multiple lymphomas. So we do need to ensure that the whole body is assessed appropriately for the presence of one of those lesions. And it looks more solid cystic, so it would usually fall into the thymoma arm of the pathway. There is a bit of a debate. So we sent out a survey following publication, and one of the most common questions that came back, about half the respondents were radiologists, was why do we follow a cyst if it's clearly a cyst? Well, I've touched on this to start with. It can be difficult to be certain, particularly a small cyst. There aren't any clear guidelines on exactly how to follow these patients up. So we're here with the guidelines to support decision making. They're not hard and fast, and you have to take each patient as an individual. It might be that the radiologists are not confident at looking at thymic MRI. It's not done everywhere, but with time and with experience, they might become more confident with that. So following it up over time, they might be able to be more confident to discharge. You do see a change in size or internal complexity over time with cysts, and they do need resection. And we also want to make sure there's no development of any myasthenic symptoms during the period of follow-up, because that also would mean that we refer for resection. But we hope that we can discharge with confidence if it continues to appear completely benign. So thymoma management, these are much simpler. They are associated myasthenia, but also the long list of other problems in the first sentence there. And percutaneous biopsy, as we used to do, is now considered not required as it's non-representative for the whole lesion. There's also been previous concern of seeding. However, the evidence for that is not very strong. So we do want to refer for VATS or RATs, reduce the risk from surgery. And obviously, any patients with myasthenia need prompt management and referral because of the fact that they could deteriorate from the myasthenia and therefore be unfit for resection. There are lots of options to be able to treat myasthenia, obviously, but we need to make sure that they're going to survive the operation and from an aesthetic risk. Ongoing surveillance of suspected early stage thymomas should be considered and discussed, particularly in the context of an elevated risk thoracic surgery. This is an area that we're working on in BTOG to create more guidelines as exactly where we should be following up, what imaging and how. So hopefully you'll hear something more from us soon on that. We have suggested that there is a monthly thymoma MDT discussion if that's available. If not, it would be in a lung cancer MDT, ideally at the centre where the patient will be having the surgery. We do recommend 1, 2 and 4 year follow-up for patients who have benign or more benign appearing lesions. Obviously, we can follow this up with MR surveillance. If surgery is declined, we can continue follow-up. If the patient wishes follow-up, but no surgery, then again, longer-term follow-up with MR is no dose, but CT can be used for older patients if required. So more aggressive lesion management. This is a mishmash of all sorts of different diseases. There are primary thymic tumours there, but there are also lymphomas, germ cell tumours and metastases, and it can be difficult to decide which. Certainly the case I've put on the screen there, I think you'd be hard pressed to say that's definitely thymic malignancy. It could be metastasis from another site, it could be lung cancer. And it can be difficult to tell whether something is a thymoma, carcinoma, carcinoid, or a sarcoma arising from the thymus if you don't have the metastatic disease demonstrated. So image-guided sampling in this cohort is really important, and ideally that should be trying not to cross more than one body cavity, but if that's the only option to get in, then that's what you have to do. It's going to support SACT and also help decide if there are neoadjuvant or induction treatments possible, depending on what it is. Obviously, for lymphoma, it would go straight on for appropriate hematological support. And we do recommend that PET is undertaken. The evidence for that is good because of the fact that it can help guide how aggressive the lesions are, particularly if you've not got metastases. There is a higher SUV associated with higher grade thymomas and thymic carcinomas or carcinoids. And obviously you would need a PET for lymphoma as well. And pleural metastases are more common in later stage thymomas, and PET might be the only way to pick these up, particularly the small drop metastases right at the costophrenic sulcus, which is where we need to be looking very carefully. So we did do the survey, as I've already mentioned. Any BTOG respondents on the call, thank you very much for your feedback. This is really helpful. It confirmed the guidelines' practical usefulness on first review. Several respondents have asked for guidelines with how to undertake specific MRI protocols for those wanting to start up a service for thymic imaging, and also a bank of illustrative cases, and a requested supporting educational material with webinars and other educational events. So this is one of those. And we're looking to support the requests in the future with an access to cases for further learning. So that's the end of my presentation. I've got some time for questions. This is the website for the Thymic Specialist Interest Group. Within that, you will be able to access and download for free the paper with the algorithm within it. And you've also then got the website for future developments that we've mentioned. Thank you very much.
Thank you very much, Rebecca. That's a great overview and also a lot of insights into the development of the guidelines. Can I just start by asking, the principal premise on the anterior mediastinal mass rests on a radiologist's ability to then differentiate into 4 different components. Is this an easy thing or common thing worldwide that it's relatively accepted, or will there be discrepancies at the outset of the start of the guidelines on this step?
I think there is a great variety. Certainly there's a learning curve. So if we look at my practice, I've been a chest radiologist for nearly 20 years, and most of my practice has been in surgical centres. And I think I've been exposed to an awful lot more than colleagues who have not worked in surgical centres, simply because I've had that throughput of cases. What do you think this is? Is it benign? Previously, we would biopsy things, we'd find out what the histology was, we get the correlation with the post-resection specimen to say, yes, we were right, or no, we were wrong. So that's all coloured my experience. But I think there isn't a lot of support for radiologists with regard to making that call when the quality of the imaging is slightly suboptimal, should we say. So for example, there's some cardiac motion artifact. For example, the patient's breathless on a CTPA, and you asked, what is this lesion that's sitting there? Is it a lymph node? Do we need to do anything? I think the other thing is you don't know what you don't know. And I think a lot of radiologists are starting to realise that they need to know more about the thymic lesions that they pick up, that previously might have overlooked them or dismissed them as just benign nodes. So I think mostly what we need to do is share the message that these are important, that the management of them has changed, So we need to be looking at the patient as a whole person, making sure that they've not got symptoms developed, making sure that they're appropriately followed up, making sure their wishes are known. Obviously, if somebody doesn't want follow-up, we shouldn't be doing it. So I hope that the algorithm is going to support that diagnostic process, because as I've already alluded to, the ability to say it's definitely this is quite challenging. Whereas if you can help your colleagues to guide them towards the right management, I think that's more appropriate. You're only really going to know exactly what something is if it's under a microscope in its entirety. So what we want to do is we don't want inappropriate resection of benign lesions. We don't want to put the patient through that. And we also don't want to not refer at the right time for resection of appropriate lesions. And that was the basic ethos of the guideline, to support these tricky cases. I think when it's barn door thymic hyperplasia or cyst, or it's barn door thymoma, it's a lot easier. It's the ones in between that people struggle with, and that's why we had this drive to improve the decision-making guidance. That's the ethos.
Thank you. So there's a question from Anand Patel. In the first two categories, which is hyperplasia and suspected thymic cyst, stability on serial imaging is an important component. And Anand wants to know if you have any handle on the malignant potential of lesions after 1 year of stability. What's the error rate for any malignancy which can happen at that time point of 12 months?
So I put a couple of papers at the bottom, and that's two of those are from the UK, one from the Oxford group, and their follow-up showed there wasn't any transformation. So they have been following up for that period of time. Like I say, the evidence is pretty scanty, so we need to grow this evidence and share it. So it could be in the future we could reduce from 2 to 1 year. But at the moment, to be able to be certain, we felt that it was better to be slightly cautious with the 2 years. But most lesions that appear simple with no interval change during that time don't then go on to be malignant. The difficulty that we have is that very rarely you do have very microscopic areas of change, and that can then lead to the myasthenia. And therefore, even if on surgical resection, there's no clearly demonstrable malignancy, the patient still needs that cyst removing. So you've got the added benefit of making sure the patient is stable and well during that period of follow-up, even if it's not actually malignant, because benign cysts rarely can also cause symptoms. So it's an all-encompassing approach that we went for. But I agree, the chance of malignant transformation in a simple cyst, proven simple over time, is very low, hence the ability to discharge. Obviously with advice for representation if they've got any clinical concerns themselves.
Thank you. We've got a question from Dr. Obaidel, who's asking, in the suspected higher stage malignancy group, percutaneous biopsy is recommended. Is there a size criteria for this? I mean, it's relatively easy if it's a huge mass and you can get a needle in, but as the mass becomes smaller and smaller, when do you decide between a percutaneous biopsy and a surgical biopsy?
So the guidance is a surgical resection, take it all out. So if it's small and it's encompassable and it's not invading a structure, it should come out. If it's invading a structure, or there is concern that you're not going to get a good surgical resection, particularly into the bones, the chest wall, then that would mean that you would want a percutaneous biopsy. Pericardium, my understanding is, you can correct me if I'm wrong, it can be resected, and focal pericardial infiltration is relatively common and wouldn't stop you from doing resection, because you should then be able to follow that up with post-surgical treatments to help reduce the risk of recurrence, including radiotherapy. And as I mentioned, we've got a paper coming out about exactly how to do that, what field you need to cover. So one of the things that we need to make sure is that we're looking at it from a post-surgical treatment perspective as well. Personally, if I've been asked to biopsy something and I can get my needle in it safely, I will do it. I mean, my smallest lung biopsy is 5 millimeters. So it comes down to the expertise of your radiologist to a degree, and also what structure's in the way. I can't biopsy through the sternum. I try not to go through the lung twice because that gives you pneumothorax and the risk of pleural seeding. So I try to do dissection through the anterior mediastinum and push the pleura out of the way. So it just depends on how you approach it. But I don't think there is a size cutoff. It's more the location, the infiltration of adjacent structures, accessibility, etc., etc.
Excellent. Thank you so much. As always, so many questions and not enough time for answers. Next week, we're going to have a rescheduled talk by Professor Heather Wakely from Stanford to talk about immunotherapy for resectable lung cancer, which is widely anticipated. Once again, thank you to our sponsors, AstraZeneca, Medtronic, and Medillion Science of Care, and especially to you, Rebecca, and also to the team for developing such insightful guidelines that help both the UK and the rest of the world better manage anterior mediastinal lesions. Thank you so much for your efforts, and also congratulations on ongoing efforts on improving efficiency in NHS care.
Thank you.
Thank you very much. Bye.
Bye-bye.